Hello everyone. Today we are going to talk about what is stroke, what are the types of stroke, and how will you identify what type of stroke in a clinical examination or in a clinical case. Then what are the causes for stroke? How will you understand different terminology? If you first start this World Health Organization definition, this will be asked by every examiner who is coming for your exams, because this is the only thing they will expect from you if they ask define stroke. Okay, stroke is a rapid developing clinical signs of focal disturbance of cerebral function with symptoms lasting for more than 24 hours or longer or leading to death with no apparent other cause of other than vascular origin. The point is, the cerebrovascular accident is the a term per se defines it. A patient is having a vascular event that leads to ischemia of the brain, parenchyma, leads to neurological deficit. This is what the definition says. Then we have progressive stroke. Progressive stroke means once the patient develops upper limb weakness, it suddenly progresses into lower limb in the right side. Then it starts to the left limb. Then it starts from being progressing into it will keep on progressing. Complete stroke means at the onset of the time the stroke will be complete. For example, if the patient developing right-sided hemiplegia, it will be set as right-sided hemiplegia. It doesn't evolve. Evolving stroke means it will increase in day by day. For example, if from it start from in a week to month, it will evolve into a full-blown stroke. This is a evolving stroke. These are some terminology you should know. What is TAA? TAA is defined as transient ischemic attack. For example, if you have a blood vessel like this, so if you have a blood vessel like this now, lot of blood vessels will be there in your for it. Consider this is MC artery. Okay, if there is a thrombus there, something thrombus is formed here. What will happen? Your anticoagulant system in your body, we have anticoagulant system do exist in our body. So what it will do, it will lyse this clot. So what will happen? The clot is removed. The patient will develop TA, then transient ischemic attack, transient neurological deficit will be there. Our anticoagulant system, what it will do, it will resolve the clot. So what will happen? The patient will be free of symptoms. Again, there can be a risk of forming the clot. So this is called TAA. Because what is happening exactly in TAA is, it is a pre-stroke symptoms. They are the patients who are developed TAA, they are more prone to develop stroke in 24 hours. So that's why you have to intervene faster. That's why you need to understand TAA is very important in per se definition. So what are the strokes we have? We have ischemic and hemorrhagic. Ischemic, we have two strokes. One is thrombotic and one is embolic and one is hemorrhagic. Okay, so total 3 stroke. These are the basic classification. For example, if you develop an embolic stroke, you should have embolus from anywhere in your body. It has to be an embolus from your venous system or arterial system, anywhere. Okay, ischemic stroke means there is some thrombus which is obstructing your MCA territory or ACA territory or PCA territory. Hemorrhagic stroke means intraparenchymal bleed. We do have lot of bleed, extradural bleed, subdural bleed, subarachnoid bleed. So these bleed doesn't cause stroke. Your intracranial bleed will cause stroke. The most common area for hemorrhagic stroke is putamen. We also have hemorrhagic strokes in thalamus, cerebellum, hippocampus, but the most common area is putamen. Then we have other strokes like venous system, venous sinus thrombosis, aortic dissection. These can cause vasculitis, aneurysm, AV malformation. These are other types of stroke. They're less than 3%. They won't ask you much in this. They will simply ask you what is hemorrhagic, what is ischemic. Then we have a lot of risk factors are there. The most common important risk factor for stroke is hypertension, because hypertension is the most important cause. For example, if you take MI abdina, what will the most important risk factor is dyslipidemia. For a stroke, it is hypertension, because hypertension will cause changes in the artery. It can be cause two things. It can cause lipohyalinosis. It doesn't cause atheroma in your brain. It's a wrong concept. Everyone will teach you the brain will develop atheromas. There is no atheroma. Only in MI, myocardial infarction, your chronic coronary heart disease will only develop atheromatous plaque which can rupture, leads to platelet plaque formation. It will block your circulation. But here there will be lipohyalinosis. That means it's the same thing like atheroma, but there is no cholesterol. There will be hyaline deposition which leads to plaque formation, that will leads to platelet plaque formation, that leads to obstruction of your brain blood flow. This is what happened in your stroke. That's why brain is always different. heart is always different. Don't apply the logic with this. But if you're developing a carotid artery stroke, for example, you are having a carotid artery athyroma. Athyromas are more common in carotid artery. You don't study, you would develop carotid arteries in MCA territory. For example, MCA artery or AC artery. It can occur. But the problem, what will happen now, it will cause carotid artery can block the entire carotid artery, that can cause globalized hypoxia to your brain. Okay, ma'am. It is not, if a clot is forming inside your brain, that means your arteries, ACA, MCA, PCA, that means those are most likely due to lipoinuria. It can be due to athyroma. I'm not saying athyroma won't form. Athyroma do form, but the most common cause is this. If anyone asking you what is the most common cause for a stroke, it can be due to the small vessel disease or large vessel disease. It can be anything. Small vessel disease most likely to hyaline membrane disease, and it can be athyroma. Or if it is a large vessel disease, for example, bigger arteries like MCA, full MCA territory, full ACA territory, maybe due to thrombus formation, or it can be due to embolus formation, or it can be hemorrhagic. Okay, ma? So read those. What are the things you need to know in risk factors? Understand, hypertension, smoking, diabetes is different factor for everything. Atrial fibrillation, your AST, these things for your embolic shock. Because AST, what will happen? There is a channel is there. If you develop DVT, what will happen? Your clot will come into your right atrium, bypass your left ventricle, enter into left atrium. Left atrium, it will into left ventricle and enter into the system circulation and enter into a vein, that can cause stroke. The same thing, atrial fibrillation, atria will contract less. So what will happen? There will be stagnation of blood. The which of triad, what will happen? Lead to stagnation of blood due to clot formation. The thrombus will sitting in your atria. Whenever there is a disturbance or something happens, the clot will break off and enter into systemic circulation. It can cause stroke, renal infarction, bowel ischemia, whatever the embolus is going, it will cause the symptoms. Peripheral ischemia, if you studying this embolic phenomena in peripheral vascular disease, it becomes surgical case, the same thing. Then we have how to localize a stroke. For example, from the history itself, we have to say this is thrombotic or embolic, because examiner will ask you what stroke it can be. So we start with this thing. This is a very important topic in your case discussion. Whenever you presenting a history, they will ask you thrombotic stroke, when it will occur. So mostly it will in the night time, early morning mostly, because that time when in mediator is there, it's called tissue plasminogen activator inhibitor. The main thing, the name is very big, but don't be afraid. The main thing for that factor is to make the clotting system to anticoagulant system. You have two system in your coagulation system, anticoagulation system. That molecule activity will be high in the early morning times. So what will happen if your anticoagulant system is not in too much in defense? What will happen? The people who are more prone for develop thrombus, this is the time period they are more prone for thrombus development, because in early morning time this factor will be very highly active. So that's why leads to there will be a clot formation in your brain. So thrombotic stroke means you will develop in the early morning. Embolic stroke, whenever it can develop, but mostly it lead to activity, because whenever you do activity, you will have a sympathetic stimulation, you will sweat more, you will produce some heat. A sympathetic system will be activated. You will have increased heart rate, increased breath rate. So there is some jerky movement, not jerky movement, some disalignment in your circulation that leads to breakage of blood. So mostly it will be embolic. Thrombotic stroke can progress. Embolic stroke doesn't progress, because embolus is a piece of thing which is break from a thrombus and enter into circulation and block the entire thing. So thrombus is a growing thing. Like you can obstruct your 90% blood flow, 100% blood flow. It can progress into up to the half of the artery, wherever it can progress. Okay, ma'am. The same thing, hemorrhagic stroke also do the same thing. You will occur in most likely due to activities, but hemorrhagic stroke is not actually present with weakness. It doesn't have TIA. If you have TIA means it can be thrombotic or embolic. The people will ask you, like examiners will ask you, okay, if the patient have a TIA, you can say it is a hemorrhagic stroke? No, we can't say, because hemorrhagic stroke per se is there is a bleeding, but TIA means there is a blockage. Simple. Then we have for a hemorrhagic stroke, you will raised ICT symptom, headache, vomiting, photophobia, papilledema. These will be there. Meningeal irritations symptoms will be there. For a thrombotic stroke or an ischemic embolic stroke, you will have carotid bruit. For example, thrombotic stroke is saying if carotid buoy and absence of pulse is there, means that is highly diagnostic of thrombotic, because the main thing is your carotid artery can cause the thrombus and block the entire circulation of your brain. But for embolic thing, it can be possible, because embolic stroke is most commonly have a source from heart, mostly. For if you're saying a patient is embolic stroke, you have to say in the history patient is a known case of atrial dilated due to mitral stenosis, or patient is a heart failure patient, or a patient is an atrial fibrillation meds, something related to heart, dilated cardiomyopathy, restricting, anything you have to say, because that's only support you with this patient is embolic stroke. Thrombotic stroke means patient is a chronic smoker, alcoholic, and chronic hypertension, not under medication, patient is having all the blah blah thing they have, even CAD can be there, chronic kidney disease can be there, anything can be there, but patient is more prone for those, these people are more prone for those is thrombotic stroke. Hemorrhagic stroke is purely depend upon the patient condition. For example, most common intracranial bleed are due to high level of BP1. The same thing for thrombotic also, hemorrhagic stroke, hypertension can cause both. It can cause ischemic as well as thrombotic as well as hemorrhagic. So meningeal irritations will be the main thing. For hemorrhagic, you can see in first, if patient is coming to an ER emergency room, means what you should do is take a CT. CT is non-contrast CT. Why is non-contrast? Blood you can see the blood in the CT film. If it is hemorrhagic stroke, your treatment of management will be different. If it is thrombotic stroke, your treatment of management is different. You take a CT within 4 hours. 4 hours is a golden period for a stroke management. What will happen is, once you confirm that it is not hemorrhagic stroke, you will start with antiplatelets. If it is hemorrhagic stroke, you have to reduce rise ICT. Patient will have Cushing's triad, bradycardia, bradypnea, hypertension. So you need to reduce the BP, not too much, up to a level. For example, if a patient is having hemorrhagic stroke, the ideal BP should be 160 by 120 or 100. This is the most 160 by 100. This is the most ideal blood pressure. You should not reduce the BP less than 120. If you reduce the BP 120, what will happen? The ischemic penumbra will increase. For example, already there is bleeding is there. What you are doing? Why this BP is high? To perfuse the ischemic part. That's what your body is trying to do. What you are going to do, if you reduce the BP, means what will happen? The blood flow will cut off. So the hemorrhagic part will lose the blood supply. There is a bleeding is there, that's why your heart is and your blood vessels are constricting, there is a BP shooting, so that's why your hemorrhagic part will getting the blood supply. So you have minimum trauma. So if you should have to reduce the BP to extent, so the perfusion also, so you have to give monitor. The monitor, what will do, it will reduce your intracranial tension, so it will take care of your intracranial tension. Then you have to ask the patient to refer to a neuro surgeon or interventional radiologist or someone. They should do a clipping procedure. They will do interventions from from your artery, and they clip the vessel, or they will shut the bleeding with embolectomy, something. Okay. So what happens next is you have to localize the stroke. So for next video, we will see how to localize a stroke. So I will tell the gross idea of how to localize a stroke. Cortical stroke, subcortical stroke, midbrain, pons, medulla, and your cerebellum. These are the strokes. So each area have specific amount of symptoms. So you have to understand if it is if this patient is having these amount of symptoms, this is cortical stroke. If these symptoms are there, this is subcortical stroke. If this is there, this is midbrain, this is pons. You have to localize a lesion, because mostly they will ask you cortical and subcortical, maybe midbrain, and they can ask in Viva. But the most common thing you need to understand is cortical stroke, subcortical stroke. Simple. Okay, bye.